just start this next session this morning. And before I start out, I also like to thank Janusz, especially for inviting me here to Cracow. My daughter told me it's one of the most beautiful cities in Europe because she has been here already twice. And my experience with Poland dates back about 15 years ago when George Simbrunner invited me for the first time to give a talk in a IPOKRaTES seminar in Katowice. So this was quite an experience 15 years ago, and I'm very happy to be back now. So what you can see here is not our hospital. It is a lake close to Munich. And if you ever come down south to our region, you should visit this lake. It's one of the most beautiful lakes in Bavaria. And down there you can see the highest mountain of Germany, the Zugspitze, which is just overlooking this area. Now, I'd like to start on a topic that is rather a practical topic. And when I was asked to give a talk on that, I was thinking, well, there are a lot of neonatologists down here, so what are we going to talk about? But if you think about that more profoundly, then I realized that over the years that invasive mechanical ventilation is kind of disappearing by applying continuous positive pressure ventilation as well as non-invasive ventilation to our patients. The skills of intubation are kind of disappearing slightly. So it's probably a good idea to think a little bit about intubation, but if you go into the literature, there's very little data actually to advise us how to proceed. And luckily, we are not going to intubate this guy, whom I met in South Africa. It's a male elephant that was chasing us, so we rather ran away. So what are we going to talk about? When and whom to intubate. Where to place the tube, what about medications, and I also want to very briefly go through some cases of difficult airway access, and of course a little bit about long-term consequences. So, when to intubate? Actually, there are a lot of studies that tried to establish criteria when to extubate, but if you look into intubation criteria, it's rather scarce, and still, to my knowledge, this is more or less a clinical decision. However, in large randomized controlled trials, it is necessary to kind of define criteria in order to be able to compare patient outcomes. So in the support trial you're all aware of, where the initial treatment of preterm infants was randomized to either receive CPAP or to be intubated and receive surfactant. The criteria to decide for intubation were an increased need of oxygen, 50%, to achieve saturation of 88% at least over 1 hour, or some sort of hypercarbia at a PCO2 of 65 millimeters mercury, or blood pressure that was low for gestational age for more than 4 hours. So already you can realize that those are quite arbitrary numbers that are not really based on evidence. If you look into the COIN trial, which is the Australian study, where initial treatment with CPAP was compared to intubation surfactant, you can see that again, inspired oxygen played an important role with a 60%. However, there was no saturation specified. Peter, you correct me if that's true. And there was a criterion of acidosis being 7.25 and or a CO2 retention of above 60. However, there were other criteria like apnea, more than 6 stimulated in 6 hours, or 1 requiring positive pressure ventilation. So if you look through the literature, most of the studies that define criteria to start invasive mechanical ventilation are using parameters comparable to those. And to draw the conclusion from that, probably the best suggestion is to kind of develop for your own unit a procedure or a operation outline where you define an FiO2 value to achieve a certain saturation within a normal range. And we heard about already the normal range from Peter. So a suggestion might be after birth at several hours of life, 85 to 95, or according to Jennifer Dawson's values. You might think about respiratory acidosis as an indicator of intubation. However, 7.25 is also not really evidence-based. Could just as well say 7.2 is fine for me if the baby's doing well. And, oh, sorry. Here you go. And you might also take the PCO2 as one value. And again, there is no real cutoff value which indicates that you need to immediately intubate your baby. What I think in clinical life is really important, and we heard about that, to look at your baby. So clinical signs for respiratory distress should be taken seriously, especially if pallor or systemic hypotension develops, as an indicator of blood distribution from the systemic musculature into the diaphragm, indicating that this baby is at respiratory distress and needs further help. So these are only suggestions condensed from available literature. How about endotracheal tube placement? So I'd like to make a little poll here. Who of you is putting an endotracheal tube into your patient's orotracheally? Could you just raise your hands? Who is putting it in nasotracheally? So this is about 50-50. That's very interesting because these, of course, are the two possibilities, the nasotracheal or the orotracheal route. And so traditionally in our hospital, we use the nasotracheal route. In Australia, when I visited Peter last year, they are using the orotracheal just as well as the Americans. Most of them use the orotracheal way. Which one is better? We don't know. However, when you decide to use the nasotracheal route, there are several things you have to take into considerations. First, you have to be aware of the anatomy, which is that there are the conchae nasali, which are protruding into the nasal cavity from the lateral wall of the nasal cavity. And you have the lower and the upper. And when you nasotracheally intubate, you should always aim to have your endotracheal tube passing through the lower, below the lower conchae, because otherwise you might run into trouble. Now, are there data available regarding the two routes? And if you look into the literature, actually there are very, very few data. There's one Cochrane review on this issue by Spencer and Barr from 2009, who identified only 2 studies that were comparing these 2 different routes. And the conclusion of this meta-analysis with only a very few patients actually was that there's not really evidence-based benefit for one of these strategies. However, with the nasotracheal route, the failure of intubation is not significantly, however, tends to be increased, and there is a increased post-extubation atelectasis in the nasotracheal route, but this was only proven by one of these 2 studies. all the other parameters did not really reach significance. So if you decide either way, you just have to know about the pitfalls. And I'd like to continue now with a case of an infant born at 24 weeks of gestational age. Because perhaps you can turn down the lights a little bit, because I'm going to show some pictures, please. Okay, turn down the lights a little bit. Thank you. And this preterm infant was 500 grams, needed intubation by the decision of the attending physician in the delivery room, and was initially not improving. So after starting bagging over the nasal tube, this ET tube was withdrawn, and it turned out there was some bloody secretion from the nostril. And now, if you look again at the anatomy here, then you can easily see that there is a possibility to falsely put this nasotracheal tube in place if you are not taking into consideration these conchae and the way to go into the nasal cavity. And on the first ultrasound, after this baby was finally intubated from the other nostril, it turned out there was this canal visible. So what happened? Actually, what happened is that by pushing in the endotracheal tube into the nostril, it perforated the anterior wall of the basis of the skull and penetrated all through this brain. There's an MRI picture of this infant, and you can see this canal going all through the white matter up until the gray matter of this infant by just pushing the endotracheal tube through the nostril, through the lower ethmoidal cells into the brain. So by putting a nasotracheal tube into the baby, you have to be aware of the anatomy. And this is why I have a little film here to present to you, where I'd like you to just imagine where the endotracheal tube is going. So we took a mannequin here, and now you can see the endotracheal tube entering the nostril with the tip of this endotracheal tube facing to the lateral wall of the nasal cavity. That way, this endotracheal tube will be guided into the side track, into the side route of the nasal cavity, reaching the right area where to go through. And only after passing through that, you should start to turn the endotracheal tube in that way that the tip is facing downward. And then you are assured that your endotracheal tube is advancing through the lower route of the nasal cavity. And this can be assured by the endotracheal tube by just looking at numbers or your radiographic line in the wall of this tube. And usually this radio-opaque line in the tube is advancing to the very tip of the endotracheal tube. And the numbers on the opposite side. So if you push in this endotracheal tube, you have to always be aware where the tip of your endotracheal tube is actually located. Another way of facilitating endotracheal intubation, both on the nasotracheal as well as the orotracheal route, is a video laryngoscope. Who is a video laryngoscope available in his unit? We do now. Okay, so very little people do have that, but it's actually very convenient, especially because this optical device has a 45-degree angle of visualization. As a result, you don't need to push your laryngoscope too much in order to see the entrance of the trachea. And again, I've prepared a little film for you where we use this laryngoscope in the, oh, sorry. Oops, once again. Right here, where we used it in the mannequin, and you can nicely see the epiglottis here, you can see the vocal cords here. And what I again wanted to point out during this procedure is that you have to be aware where the tip of your endotracheal tube actually is. And if you're passing the vocal cords, it's advised that you aim the tip either to the front or rather to the frontal side in order to facilitate the introduction of your endotracheal tube across the vocal cords. And now you can see there, this is a nasotracheal intubation without using any machial forceps at all. Now, how do we prove, if we don't have a laryngoscope with a video, or we are not really sure whether or not our endotracheal tube is in place, that we actually did the intubation as we intended to do that? So there are several ways, and the ILCO guidelines suggest that you might use a CO2 detector at the end of the endotracheal tube. Who is using the CO2 detectors in his unit? Okay, we don't. What other ways are there to actually prove your endotracheal tube is in the right place? One of them would be if you have a respiratory function monitor, of course. And George Schmelzer from Peter's unit, when he was still there, did actually a trial where they tried to find out which of the two devices is actually telling you more the right intubation. There is the CO2 detector, a PDCAP. You can also have other ones from other brands. Or you have the flow sensor. And you can see that the PDCAP actually is having a quite nice positive predictive value. However, there are also false negatives, and the same is true for the flow sensor. And we just recently had an infant that was intubated into the esophagus and had a very nice expiratory flow on the flow curve by just regurgitating air from the stomach. So you might be false here. Now, the next topic I'd like to very briefly talk to you about is medication. And again, I'd like to do a little poll. Who is using medication for intubation in his unit? I do. So this is, who is not using it? Just contrary. Or you don't know? Not everyone pulled up. And who is using medication in the delivery room? When you are intubating a baby in the delivery room, which is vigorous still, but needs intubation, almost nobody does. So when you think about medication, you should be aware of the acute side effects of intubation. And there are numerous that have been actually described in the literature, and a lot of them are reviewed by this paper of Kumar in Pediatrics 2010. And of course, it's hypoxemia, it's bradycardia, but also intracranial hypertension due to coughing or crying or just fighting the laryngoscope might take place, systemic hypertension. But you might also induce pulmonary hypertension or, quite important, traumatic injury by the laryngoscope to face, eyes, tongue, gum, teeth, and brain, as I've shown you. But there's a new study also just published in pediatrics where they looked into brain activity during intubation. And interestingly, they were able excuse me, to identify brain depression during intubation right when the laryngoscope blade is entering the mouth of the child. And if then, after that, you also give surfactant, the depression of your EEG might even be worse. Now, just like a poll we did right here, in Paris, Durmeyer did a survey in 12 units in Paris where he not only sent out a questionnaire but actually was visiting all these units and recording with independent observations whether or not medication was used for elective intubation in the units. And as you can see, there's a huge variety of the usage of medications, but in total, 44% of these units did not use any medication during intubation. When I have young residents in our unit and they want to go ahead and very rapidly intubate a baby without giving any medication, I usually say, you sit down and I intubate you without any medication. And then I'll ask them whether it's fine or not. Because we know nowadays that the pain perception, even in the smallest infants, is present already in a 24-weeker. So the goal of peri-intubation medication would be to eliminate pain and discomfort without adverse effects, of course. And the standard ways to do that are, of course, analgesia, sedation, and perhaps relaxation. That is open for debate. Now, the most popular analgesic drug, of course, opioids are the ones to use in a situation like that, is morphine. So who would use morphine as a induction medication in his unit? So a few would. The problem about morphine is that you have to be patient. If you're using morphine as an induction medication, you have to wait at least 10 to 15 minutes to be sure that the analgesic action of morphine has really taken place. If you take morphine and apply it and then immediately go ahead, you can just as well go without morphine. The recommended analgesic drug in neonates and preterms currently is fentanyl at a quite low dose, at an analgesic dose with an early onset at 1 to 5 minutes and a duration of up to 60 minutes. However, if you use fentanyl, you all experience probably the chest wall rigidity as one of the major side effects that you need to know and you need to treat immediately if fentanyl is applied too rapidly. A new drug is remifentanil, not so new anymore. It's quite a while on the market. And the nice thing about remifentanil is that its onset of action is very rapid and the duration of action is quite short as well. However, in neonates, there are only limited data on that. How about sedation? Sedation has been traditionally applied to preterm infants and neonates with midazolam, which, of course, is a drug that works well with fentanyl. However, you again have to take into consideration that it takes a while for onset. You can have paradoxical reactions, and it increases the possibility of systemic hypotension. So other drugs have been suggested. Thiopental is also quite widely used. And a drug that has been introduced into neonatology kind of subcutaneously without any data supporting the use of this drug is propofol, which is acting very rapidly and only short term. However, the side effects in preterm infants are not very well established. And we had one infant that was intubated on a combination of propofol with fentanyl that went into untreatable bradycardia due to probably AV blockage. So you have to be aware of these side effects, and you have to take all these possibilities into consideration. So who would routinely apply muscle relaxants to a baby for endotracheal intubation? Who would do that routinely? Okay, some of you. So this is also not very well studied, actually, whether or not this is advantageous. Of course, it's facilitating intubation. And several drugs have been suggested, from the non-depolarizing drugs as well as the depolarizing drugs, succinylcholine. And all of these drugs have a quite rapid onset of action. And despite pancuronium, which is probably no longer used, most of these drugs have a rather short duration time. So to conclude, medication, yes, we should establish a standard operating protocol for your unit to use medications in neonates while intubating electively. It's still under discussion whether or not you should use drugs for the emergency intubation. Probably in an awake infant that is fighting intubation. And you have to decide for probably one set of drugs in your unit so that everyone, both nurses and doctors, know all the time what drugs are standard drugs to be used. How about using vagolytic agents in order to prevent bradycardia by using a laryngoscope? Again, there is very, very little data supporting that, and I know some units do it, and also in our unit some people do use that and others don't. So, are there any questions so far before I proceed? If not, I'd like to focus now on problems that are the ones no neonatologist really loves to face, difficult airways. So the reason for difficult airways are numerous, and I don't want to go into all these details, and probably those of you who have been around for a while have seen quite a bit of these difficult airways to maintain. And this is one of a rare occasion, macroglossia, in an infant that was born at term and was initially supposedly normal on prenatal ultrasound. However, it turned out that it was born with macroglossia. And macroglossia is a typical symptom of Wiedemann-Beckwith syndrome, which also was true for this infant. And what you can see here is that this baby received intubation due to the obstruction of the upper airways by just pulling this tongue out with a maculed forceps, which is quite rude, and other ways of maintaining patent airways might have been taken into consideration if you would have known beforehand. Another quite common possibility of upper airway obstruction is microretrognathia. So this is an infant that we took care of a couple of years ago that was susceptible to have an upper airway obstruction due to the findings of polyhydramnion, and on fetal MRI, it was obvious that this infant had some facial dysmorphic issues. As you can see here, there is the forehead, there is the nose, there is the upper lip, and then there is nothing. So this is a severe case of mandibular hypoplasia, Pierre-Robin sequence, and we knew about this problem beforehand, and prior to delivery, we had all equipment the pediatric surgeons, the pediatric bronchologists in the delivery room when this baby was born, as expected, with a severe upper airway obstruction. So in an infant like that, you might consider to even secure the airways before the umbilical cord is clamped, actually. So this infant had the so-called Nager syndrome and was subsequently put on a tracheal cannula. Other possibilities, more common, are laryngeal malacia with an omega epiglottis or a laryngeal cyst, or if you have recurrent aspirations in infants, the laryngeal cleft might be one of the reasons to consider. More difficult and actually chaotic are the so-called congenital high airway obstruction syndromes. Those are entities of upper airway obstructions that are preventing fluid to drain from the lungs during fetal life, resulting in a distension of the lung, in eventually a fetal hydroptic presentation, and maybe due to laryngeal atresia, tracheal atresia, laryngeal webs, and all of these other diseases that might be considered prenatally, and the management of these infants should be centralized in units where a so-called exit procedure is possible. What is exit procedure standing for? It's the ex utero intrapartum treatment, where actually the baby is still on the placental perfusion and support and is then secured with regard to the airways prior to cord clamping. So this is an example from the literature where you can see fetal ultrasound with their hyperechogenic lungs that are distended. You can see hydroptic fluid in the abdominal cavity, and you can see a distended trachea in this infant. Here's the rib cage, and as a result, this infant had a tracheal atresia. You can see the polyhydramnion, you can see the hydrops of this infant, and this is an exit procedure where you can barely see the child, which is down there, and you can see both Andreas Schulze and me. There's two obstetricians, there's a midwife applying surfactant to this infant. The infant is already intubated. We have pleural drain put in both sides of this infant. And this infant still is on placental perfusion during this procedure and did well after being in the unit. But beside these very intense procedures, I'd like to also point out that sometimes very simple devices might help you to secure an upper airway, especially in an infant with, for example, choanal atresia or macroglossia or micrognathia, where you just put in the appropriate size Gödel tube in order to facilitate the normally through the nose breathing infant with an oral airway. Now, what other tools do we have to facilitate difficult airways? So one tool I'd like to show you is this flexible stylet. This stylet has just recently been made available, and this is actually a very nice tool because you can attach this stylet. It's a tube with a bending at the tip, and you can see tip holes there. And you can actually attach it to a ventilator or a gas source and insufflate just oxygen into a child and do an apneic oxygenation while you're trying to establish the upper airway. And you can use this as a guidance for your endotracheal tube as well in order to even intubate a baby without actually seeing it. The other possibility is the ultra-thin bronchoscope guided intubation. Here you can see one of these bronchoscopes. They are very tiny and can pass through a 2.5 endotracheal tube. And if you have a difficult airways, you might want to use this bronchoscope, which can easily pass even very narrow airways. You can see here the entrance into the pharyngeal cavity. Here's the epiglottis. Here you can see the aryepiglottic fold. Now we are in the trachea with the endoscope, and then you can easily advance your endotracheal tube. Down there you were able to see the bifurcation, and now you advance the endotracheal tube into the trachea and withdraw your bronchoscope from the trachea. Here you could see the black end of your tube, and now the bronchoscope disappearing. And of course, as I already mentioned, the tracheostomy is a final possibility to secure the airway. So what are the long-term consequences of intubation? Of course, vocal cord damage, impaired movement, and laryngeal tracheal stenosis and inflammation. And this is an old example of a 23-weeker who was mechanically ventilated for 16 weeks and subsequently developed a 30 to 40% stenosis of the upper trachea that needed anti-inflammatory, antibiotic treatment for a long term, and also a tracheostomy. Another side effect of long-term intubation are ring-like stenosis, like you can see here in the subglottic stenosis. Or more recently, we started to see an increasing number of infants developing something like that. And this is a very recent case of an infant that was born at 27 weeks of gestation, did very well initially on CPAP, then subsequently needed mechanical ventilation for only 3 weeks. However, after discharge home, developed an increasing stridor. And so this infant eventually went to bronchoscopy. And what our bronchoscopy team found there are several tracheal cysts that were fluid-filled. And we haven't seen that before, and talked to our bronchoscopist saying that this now increasingly happens, and we don't know why. So it's a very interesting observation we have to look into. What the suspicion is that due to endotracheal intubation or re-intubation in infants, probably there is a shear trauma to the epithelium of the trachea, resulting in impaired drainage of secretions from the tracheal epithelium and subepithelial glands that finally might lead to retention cysts in the tracheal lumen, leading to airway obstruction. And laser therapy usually cures this disease. So the best thing would be to prevent, of course, intubation with antenatal steroids, early surfactant treatment, and extubation. And we will talk about non-invasive respiratory support, hoping to not intubate this blue-tongued giraffe. So thank you very much. Any questions?
Okay, yeah, from Denmark. I think one of the problems a little later on is leakage. And we've started using tubes much larger than we would have done before.
Okay.
Any comments on the size of the choice of size or other ways to prevent leakage?
Yeah, that's a very difficult question. I mean, the small size tubes we have available now are the 2.0, and if you have the ones with the reduced wall size, that's the tiniest tube. And of course, in most of these infants, tube leakage develops over the first days of life when the lung becomes less compliant with an endotracheal, with a trachea being rather compliant, then you can barely do anything against it. Then we eventually would also change tube size. However, over time, the leakage comes back, more or less. So I'm not sure about increasing tube size is the right way to go. There are new endotracheal tubes now that have an inflatable balloon for neonates as well. They start at 2.5 millimeters outer diameter, where you can actually control the leakage. And I have not a lot of experience with these endotracheal tubes. However, know about some units who routinely use them starting at 2.5. Long-term outcome, I have no idea about these ones. Yeah. Are you using blockable tubes? No, you're using the Portex tubes with the small wall. Yeah, but you start with 2.5, right? In all infants. Yeah. But then also leakage develops, more or less, especially in the very sick ones.
You're right. It's when you're trying to use volume-targeted ventilation, that combination is difficult. Maybe we are more prone to try and get rid of that leak, so we can effectively use volume guarantee or volume-targeted ventilation, and that I think was the potential problem you were alluding to. Yeah, it's difficult.
Other questions? Yes, please.
I'm not sure that I could understand you. You think that we should use medication in delivery room for the new intubation?
Good questions. We actually only use medication in the delivery room in a very vigorous infant. In an emergency intubation where we have a compromised infant that is barely moving, there are no data whether or not we should use it. However, if you look at the EEG tracings, I think we should think about using drugs in the delivery room as well. But there are no data, actually. Yes, please. Absolutely, yes. But if you have a flow sensor attached to your tube, then you can control for the leakage. And so when you try to less inflate your balloon, then you have a 10 to 20% leak, then you might be quite confident that tracheal necrosis won't take place. I think there's one observational study on these endotracheal tubes now available, but no randomized trials. Yes?
I think some leakage might be a bad.
Absolutely. Yes.
So don't be afraid of maybe 10%, 50% leakage.
Yeah. We would rather tolerate some leakage than go ahead and intubate with a large endotracheal tube. But the thing I really observed is that in our unit, with residents staying shorter and shorter periods of time and less infants being actually invasively ventilated, these skills of intubating are kind of vanishing slowly. So I don't know about whether you observe that as well. So I think it's really important to think about that. There are no further questions. Thank you. We proceed with Anton.